And great. So Dr. Ouslander, I'm happy to share your slides if you'd like me to, or if you want to go ahead and do so, whatever.
No, I
is
can
easiest for you.
do that, I think.
Perfect. Yep, you should have the ability to do so.
Okay. How about that?
That's perfect.
Let me make it larger. And put it on slideshow. I'm assuming everybody can see that.
Yes, sir. You're good to go.
Okay. Well, hello, everybody. I'm pleased to be able to meet with you. Dr. Simmons asked me to give an update on incontinence and overactive bladder and management of urinary tract infections. I just got an email from her. She's stuck on a study section meeting. So she said she would try to join a little bit later. I understand. I just want to make sure I know who I'm talking to. So I understand that the people that are attending are people who are part of a coalition of facilities. Is that correct?
Yes, so the project includes nursing homes throughout the Middle Tennessee area, and the folks who typically join these calls are, DONs, ADONs at the nursing home. Sometimes you'll have an administrator or another nurse who works on the floor. So that's the general audience.
Okay, great.
Yep.
Well, welcome to everybody. I hope that's who I geared the talk to. So I hope it's useful. Please write any questions in the chat box, or you can always just unmute yourself and ask me to clarify something at the time. So I have not been working in this area for several years because I've been working on another topic I'll be talking about, and that's reducing unnecessary hospitalizations from nursing homes, as well as other settings. But when I was updating this talk, it brought back a lot of very good memories about working with Dr. Simmons and Dr. Schnelly at UCLA. We had multiple studies going at once, and we met at least a couple times a week, and we used to we would review data and fight with each other, and it was a lot of fun. We'd go visit the people who were working in the nursing homes and the people participating in the studies. So it brought back a lot of good memories. I currently teach in a very nice nursing home, and as part of a CCRC, as part with our medical students and geriatric medicine fellows. So even though I'm a geriatrician, I'm still involved in teaching and doing various projects. So the objectives for today are to identify effective methods to assess urinary incontinence and the implications of effective management, to discuss non-pharmacologic and pharmacologic options to manage incontinence in older residents of nursing homes, and to review guidelines for management of UTIs. So this is older data. It's probably outdated, but the prevalence of incontinence in nursing homes is probably now close to 70%. And one of the things that we know is that a lot of the residents who are incontinent are not on any type of toileting plan. And as we go through this presentation, you can decide whether that's appropriate or not appropriate. And we can discuss that at the end of the talk if you'd like to. So I love this cartoon where the lady's in the urologist's office and she says, "My bladder is more active than I am." I'm getting to that point myself. I remember seeing a person in a continence clinic that I ran at UCLA, and I asked her how her bladder was, and she said, "Busy." And that was the best one-word answer I've ever gotten from a patient. But overactive bladder is a syndrome that is just as common or more common than just pure incontinence. And it's urgency with or without incontinence. Urinary frequency defined as greater than 8 voids in 24 hours. And nocturia, which is typically defined as awakening 2 or more times during normal sleeping hours. But in order to define that, you need to know what the normal sleeping patterns are. If somebody's sleeping 10 hours a night, it might be normal to void a couple of times. So there's this overlap between overactive bladder, urge incontinence, and stress incontinence is the other major type of incontinence. And then there's mixtures. A lot of older women have symptoms of both urgency and urge incontinence and stress incontinence. So this is a picture that is a real picture that's somewhat embarrassing, actually, because I look at this picture now and I say, wow, I think I was at least 50 pounds heavier in this picture than I am now. But the point of the picture is that I was working with a nurse practitioner in a nursing home, and we just ran into a blockage of diapers in the hallway. We couldn't get by the diapers, and that's, as you all know, that's a big expense. And again, whether that's the most appropriate way to manage people, we'll talk about. But not everybody in a diaper is happy like this guy. Patients, residents, and their families prefer not to just be told to go into a diaper, and they're not happy like this guy. I've shown this slide in a lot of lectures, and after many of them, people have come up to me and said, "Is that you in that slide?" And I would always say, well, it's starting to look like me, but it isn't me. So there are impacts of these conditions. It's bothersome to residents. It causes morbidity. It can contribute to skin irritation and pressure ulcers. A major related morbidity that some may not think about is falls. A lot of falls in nursing homes occur because residents are attempting to get to the toilet. It's time consuming for staff. As you know, it's troublesome for families, and it is costly. And it can be dangerous for staff as well. I don't know if any of you have seen this happen. I have, but more often I've seen this type of situation where a woman who's a nursing home resident got up in the middle of the night to go urinate, and she didn't make it, urinated on the floor and slipped in it and fell and broke her hip. And then she was confined to a wheelchair for the rest of her life. So for me, when I evaluate or assess the need to to do further evaluation and treatment of incontinence in nursing home residents. This is one of the big factors that I consider. Is what is the fall risk associated with urinary urgency and urgent continence. And there are many other quality indicators that you're familiar with that do relate to incontinence and overactive bladder. And we'll talk about things like fecal impaction and urinary tract infections. So I was involved, I think it's still FTAG 315. I was involved in with some nurses and others to revise the surveyor guidance for the tag that's related to incontinence. And the tag is designed to make sure that incontinent residents are identified first. They have some type of assessment and they're provided appropriate treatment. Second, indwelling catheters are not used unless there's a medical justification. And if there isn't, the catheter should be removed as soon as possible. And residents receive the appropriate care to prevent urinary tract infections. And I'll talk a good bit about preventing urinary tract infections in a few minutes. So as I said, we did have the opportunity to work with the survey team. It was a unique opportunity because we actually did a video that was produced by CMS and was distributed to all the surveyors across the country. And what we emphasized was resident choice in incontinence care, assessing people for reversible factors, which could contribute to incontinence, targeting interventions based on the assessment, perineal hygiene, indications to treat a urinary tract infection, and the use of catheters and catheter care. So we covered all those things in the guidance. So incontinence is similar to other conditions that you might work on in improving quality, in the quality improvement program in a nursing home. And there's several basic principles. The leadership must make it a priority. And there should be a champion for a program like this. Develop simple policies and procedures that the facility can adhere to. You don't want to have policies and procedures that you don't adhere to. You can get in trouble for that. Use simple standardized assessments and monitoring forms, and I'll show you some examples. Target the treatments and document the rationale. And you can actually use principles of continuous quality improvement to monitor outcomes. I won't get into that unless people want me to, but it's a very interesting strategy and can be effective. So incontinence, urinary incontinence has been divided into acute or transient incontinence and persistent incontinence. But I also look at the transient incontinence as having potentially reversible factors related to it. It's common in post-acute patients who are continent when they're at home and then they get an illness and get immobile, deconditioned, may have altered mental status or delirium in the hospital. And that's why they're incontinent. And that can resolve with the resolution of the acute illness. Acute transient incontinence is less common in long stay nursing home residents. Persistent incontinence is usually multifactorial. And even though it's been present a long time, potentially reversible factors can contribute to it. So the types of persistent incontinence have been defined as urge incontinence, which talked about in terms of overactive bladder. The symptom is having to void precipitously or urgently and feeling like you have to rush to the bathroom. Stress incontinence, which is actually common in younger women after childbirth, and sometimes with exercise. And it's just, the stress is not mental, it's physical on the bladder. And I'll show an image of that. And just physical forces pressing urine out of the bladder. There's what's been called overflow incontinence in the past. It's not technically called overflow incontinence, but it is incontinence that's associated with poor emptying of the bladder, which is very common. I've recognized that my own symptoms of urinary frequency probably arise from not emptying my bladder fully enough. If you don't empty your bladder fully enough, you're not going to have a long time before you have to go again. And that's part of the pathophysiology of incontinence in a lot of older people. And then there's functional incontinence, which in very impaired nursing home residents we believe it's a very prominent factor. And I think some of the data that I'll show you on prompted voiding proves that. It proves that a lot of the incontinence is functional in nature. That is, people need a toileting assistance to be continent. So the things that I'm going to talk about, the assessment and some of the management strategies are all embedded in clinical practice guidelines. They were in the initial resident assessment protocols. And so these are things that these are strategies that are at least expert recommended, and some of them are evidence-based. So the basic assessment of incontinence includes a history and some type of bladder record to determine voiding patterns. A physical exam that includes a pelvic exam and a rectal exam, even superficial. A urinalysis, if someone has new or worsened incontinence or a suspected infection. And a post-void residual determination in people who are at risk. And I'll show you who those are. Because you can't determine by physical exam all the time whether there's significant residual urine. And the key points are to assess the voiding and incontinence patterns and habits, to identify reversible factors that you can try and correct, to determine if there's a need for further evaluation. You don't want to be treating a bladder tumor with a toileting protocol, and to base treatment on findings and patient, resident, and family preferences. Now, there are age-related changes that occur that contribute to incontinence symptoms in older nursing home residents. So in women, the pelvic floor anatomy is often not normal. So in the normal case, the base of the bladder and the proximal urethra is inside the intra-abdominal cavity. And when you increase pressure in the intra-abdominal cavity, like is illustrated here, it helps close the urethra. But if the bladder is dropped down and the junction is outside the intra-abdominal cavity, increases in intra-abdominal pressure from coughing, laughing, sneezing, bending, exercise can actually physically force urine out of the bladder. So that's a big part of the pathophysiology of stress continence in older women. And this, these muscles get weakened and deconditioned. The pelvic floor muscles, the voluntary muscles, and the smooth muscle of the urethra is estrogen dependent. So all those things make the pelvic floor, can make the pelvic floor weak. And also, women tend to have older women tend to have a dropped bladder or a cystocele. Now, what I'm showing here is not a official grading system. This is, I'm very simple-minded, and this is based on hundreds and hundreds of pelvic exams in older women. But normally, if you do a vaginal exam and you just put a speculum in and press down, you don't see any bladder dropping down in a young, healthy woman. In some women, there's some dropping of the bladder. Some women, it's larger, and some women have a large cystocele that actually you can just actually, you don't have to do a full pelvic exam to see this. You can just spread the labia and see the bulging bladder. And that contributes to not only incontinence, but urinary retention. So women with a large cystocele, they can be incontinent, and they sometimes will feel like they have to go and sit down and go, and then stand up and have to go again because they've left urine in the cystocele. And that can, leaving urine in that cystocele can contribute to recurrent urinary tract infections. And then there are conditions that irritate the lower urinary tract, like atrophic vaginitis. So in a lot of older women, their vaginal epithelium is very pale and is irritated. It has patches of redness and irritation. And these tissues are right adjacent to all the sensory nerves of the urethra. So that irritation can trigger urgency. And then there's what's called the urethral caruncle, which can be pretty large and inflamed. And again, you can see just by spreading the labia. And these conditions can be treated by topical estrogen. I'll talk a little bit more about that. The other thing that is important to recognize is the impact of the bowel. So one urologist that I worked with at Emory used to talk about how the bladder and the bowel are like two heavy passengers sitting on the same seat in a bus, and they're right next to each other. So normally, the rectum is separated from the bladder, but if you have a lot of stool in the rectum, it can press on the base of the bladder, the trigone of the bladder, where there's sensory innervation, and that can contribute to irritating the bladder. So checking for fecal impaction and removing fecal impaction is absolutely fundamental in anyone who's incontinent of urine or stool, because it can cause stool incontinence as well. There are some changes in men that create problems. So these little boys are peeing up into a window. They have no problem. They just knock the flower pot out of the window with their urinary stream. That's very different than this picture of me and some other older geriatricians who have a different urinary stream. And some of that is related to an enlarged prostate and symptoms related to an enlarged prostate. That little prostate gland causes a lot of problems. And one thing to recognize about it is that you can feel a very large prostate on rectal exam, but you can also have a part of the prostate with a median bar of the prostate that's obstructing the urethra, and you can't feel that. You can't feel that from the rectum. So even if there's not an enlarged prostate on a rectal exam, you still can have partial urethral obstruction. So the typical diagnostic assessment that we would do in people who wanted to evaluate would again be a history and some type of voiding diary for 48 or 72 hours, a physical exam, a cough test for stress incontinence, measurement of post-void residual volume in selected patients, and a urinalysis in selected patients. And this actually can be done during a trial of toileting. So if you're actually, which you'll hear, we recommend that people have a trial of toileting, 2 days, 3 days of toileting. And during that trial, you can do a cough test for stress incontinence. You can measure a post-void, a voided and a post-void residual volume, and you can capture urine for a specimen if you're going to do that. So you can do that during a trial of prompted voiding. We'll talk about prompted voiding in a few minutes. So bladder diary can be helpful in some people, mostly in outpatients. I think a good history from people can also be helpful, but I'll tell you, there's a lot of older people who drink caffeine, and caffeine, no matter what anybody says, is extremely irritating to a bladder, especially an overactive bladder. So sometimes just altering the type of fluid, the intake of fluid can be helpful. So in terms of the symptoms, we're assuming that someone is admitted to the facility, and one of the things that's identified is incontinence. There's some just basic aspects of the history that could be asked by a nursing staff or a physician or a nurse practitioner. What are the most bothersome symptoms? How far do you want to go in evaluating this problem? A lot of older people are already wearing some type of padding, and they're perfectly comfortable with that, and that may be okay. The onset of the symptoms, if they've had prior treatment, many people have tried various interventions and it hasn't worked. They haven't worked for them. To characterize the symptoms is this predominantly overactive bladder, stress incontinence, symptoms of having difficulty getting urine out of the bladder, or other types of symptoms, and then bowel habits. And I mentioned before that that you can do a comprehensive physical exam, but I think that if you're evaluating someone for incontinence, you can just do a basic rectal exam and just a superficial pelvic exam, and make sure there's no impaction, make sure there's no large pelvic prolapse or irritation around the vagina or the urethra. So because many older people don't empty their bladder, many should have a post-void residual because the symptoms are not specific, and you can't tell on physical exam. So, for example, in a person that's just normal body habitus, not even obese, I think it's hard to detect even 300 mils in the bladder. So, but for sure, diabetics who are incontinent, who may have a diabetic neuropathic bladder, neurologic conditions like a stroke or multiple sclerosis or a spinal cord injury, men, especially if they haven't had a TURP, or they have symptoms of voiding difficulty, if there are anticholinergic or narcotic medications, which can contribute to urinary retention, or a history of urinary retention. I don't know how many facilities have a bladder ultrasound, but if you're seeing a good number of post-acute care patients, you certainly should have a bladder ultrasound, because it's an important part of a bladder, whatever you want to call it, a bladder retraining protocol, and when you remove the catheter. Urinalysis to look for infection and blood and glucose is important in some patients. If a patient has long-standing incontinence and no symptoms of an acute infection, it may not be necessary. And then some people need further evaluation. Who should be further evaluated? Any patient who has a recurrent symptomatic urinary tract infections, 2 in 6 months, 3 in a year, they should have a urologic evaluation for structural abnormality in their lower urinary tract. Right before I was on this call, I was communicating with the son of a 101-year-old person that I see, and he has a lot of discomfort, urinary symptoms from a recurrent urinary tract infection that is related to a kidney stone or a bladder stone, and that's something that needs to be taken care of. Recent pelvic surgery. If someone has severe pelvic prolapse, and again, that's not hard to diagnose. If someone has a prolapse of their bladder outside their vagina, they should be considered for a surgical procedure. If they have blood in their urine without an infection, that's an indication for looking for bladder cancer. Significant urinary retention that you can't explain. And then if there are patients who undergo a trial of therapy and they just don't respond, and they're still bothered by their symptoms, then a further evaluation might be indicated. And what about reversible factors? When you're doing history and physical exam, you're always thinking about reversible factors. And I've used this acronym DRIP to remember them. So the D is for delirium. In a post-acute patient who has residual delirium, that could be contributing to their incontinence. Restricted mobility, if someone has an injury, a hip fracture or other injury, and they can't get to the toilet, that could be a cause. Urinary retention with quote overflow incontinence can be a reversible problem. I for urinary tract infection, inflammation, meaning atrophic vaginitis, and I for fecal impaction. And P for polyuria, conditions that cause polyuria, such as poor diabetic control. Usually blood sugars over about 220 will cause some degree of polyuria, and it can lead to dehydration and could contribute to incontinence symptoms. And then there are all sorts of drugs that can contribute. You all know the effects of diuretics on the bladder, especially the loop diuretics that act very rapidly. I don't know if any of you have actually taken furosemide. I had the pleasure of taking it for a little while, and it was awful. I mean, it was just awful, especially within a few hours of taking it. Narcotics can relax the smooth muscle of the bladder and cause retention, or they can cause constipation, which can cause retention. Anticholinergic drugs, drugs with potent anticholinergic action, or combinations of drugs with anticholinergic action. Many of the psychotropic drugs have them, and they can contribute to overflow or retention and symptoms related. And then cholinesterase inhibitors. A lot of physicians, in my mind, unfortunately, prescribe a lot of donepezil or Exelon for dementia. I'm not a big believer in those drugs, but one of their side effects is that they can cause urinary frequency and urgency and contribute to incontinence. So that's something to keep in mind. Now, what about urinary tract infection? Well, we did a study as part of a series of studies that asked the question, if there's a nursing home resident with chronic stable incontinence, no recent changes in their symptoms, no symptoms of an acute urinary tract infection, if you eradicated the bacteria in their urine, you gave them an antibiotic and eradicated the bacteria in their urine, would it improve the incontinence? I'm not talking about people who have the symptoms. I'm talking about people who only are incontinent, okay? And you can see that people who were bacteriuric after we treated them with antimicrobial therapy had the same percent of checks wet. And the percent of checks wet in these graphs is 3 days of every 2-hour checks. So they were essentially the same, as were people who were not bacteriuric. So we concluded from this study that chronic stable incontinence in the present, when bacteria is present, significant bacteria, you do not have to treat that as a treatment for the incontinence itself. It's not a symptom that needs to be treated. So I wanted to somewhat digress here and talk a little bit about urinary tract infections, because this can be a very confusing subject, and it rightfully so, and I'll tell you why. And recently, a group of physicians and nurses got together and developed this IOU study toolkit, improving outcomes of urinary tract infection. And it has, you can get it from the American Medical Directors Association, and it has some nice tools in it, like you can see on this slide. There's a physician order set and some guidance on what antibiotics to use. So it can be very helpful, and again, it's evidence-based and expert recommended care. One of the main points is bacteria does not equal infection. Okay, so the doctor's saying, okay, I obtained the urine, now what? And the answer is, if somebody does not have symptoms of an acute infection, don't get a urine. Way too many urines are being done. And the reason for that is that diagnosing UTI can be challenging because there's a high frequency, there's a high background prevalence of bacteriuria. And it's very common. We actually did this study. We combined a study of doing post-void residuals with catheterizations for sterile urine, and we found that in what the statistics had said, and we found was that of the women who had stable incontinence who we catheterized, and I did all these catheterizations myself, 50% of them without symptoms had significant growth of a urinary pathogen. So the background prevalence in a woman in a nursing home is about 50%. It's not necessarily a symptomatic urinary tract infection, and that's just very important to recognize that. So the background prevalence in women in a nursing home is 25 to 50%. If you just went and did sterile urine, collected sterile urines like we did, you get 25 to 50% have significant bacteriuria without symptoms of an infection, and in men it's 15 to 40%. And then once a catheter is in for a week or two, it's 100% in those people. So there have been lots of trials that have looked at treatment of asymptomatic bacteria in various populations: diabetic women, older women in the community, older nursing home residents, patients with long-term indwelling catheters, patients undergone orthopedic surgery and a transplant, kidney transplant. And treating asymptomatic bacteria has not been beneficial in those people. And it really should not be a practice that's approved, because, as you know, unnecessary antibiotic treatment can cause a lot of different complications. So those complications include infections with resistant organisms and antibiotic-associated diarrhea, which is a terrible problem in immobile nursing home residents, as you know. So even when there's pyuria, if there's no symptoms of a urinary tract infection, just don't chase it. The other thing that can be very confusing is the relationship of bacteriuria to acute confusion. So every time, does somebody have a question? Looks like somebody
I think it was just some background noise, Dr. Ouslander. Someone didn't realize that they were off mute. I think everyone's back on mute now, including yourself. So you're going to have to unmute yourself to get back going. I do just want to say really quickly, we only have about 13 minutes left. So whatever is kind of the most pertinent material, because people are going to have to hop off at 1 o'clock Central Time to get to their next meetings or to get back to patient care. So just want to provide that caveat.
Okay, but this is an important point. Altered mental status by itself is not a symptom of a urinary tract infection. Okay, and I think we're chasing too many so-called urinary tract infections and over-treating them. By every time someone has an altered mental status, to assume it's urinary tract infection. Altered mental status and and bacteria are two common things that occur commonly together, but it doesn't necessarily mean a person has a urinary tract infection. So now I can't move forward with the slides. There we go. So I'm not going to go over dosing. I am going to just mention to you that a common practice when somebody is treated for urinary tract infection is to use probiotics. And there was a randomized trial of probiotics done in nursing homes in Europe. And they found that it wasn't effective for any outcome. So that may be something we should reconsider. Prevention of UTIs, obviously good parenteral hygiene is essential. Making sure the bladder is emptying. Making sure that there's not constipation that's interfering with bladder emptying. Indwelling catheters need to be secured to the thigh. I think that's better done now if someone actually needs a catheter. There's a little bit of evidence that cranberry may be helpful. I'm still not convinced, but there is some bit of evidence. What is helpful is topical vaginal estrogen cream, which a lot of women don't like and has to be applied, or an estradiol vaginal ring. That will help prevent recurrent urinary tract infections and should be considered in addition to good peritoneal hygiene for recurrent urinary tract infections. So what about a further evaluation of incontinence? There are all sorts of sophisticated urodynamic tests that can be done to find out what's going on, but we don't do tests unless it's going to change the way you treat the patient. So I already went over some of these criteria for further evaluation, and that it would be in very selected patients. So let's talk about management of incontinence. You know, we did a kind of a patient preference study, and it was interesting because there were a significant number of patients, about a third, who of these 79 respondents, who definitely preferred a pad or a diaper because they were comfortable, it helped them sleep, and there were no skin problems. So based on person preference alone, a pad may be appropriate. So these are the types of things that we do. Supportive measures include education about bladder health, environmental strategies for safety to get to the toilet on time, using a commode, or I frequently recommend for men a urinal. That's a really good fall prevention intervention. If men can use a urinal at night, garments and pads and catheters. So we don't want to just put someone in a diaper and tell them to void in it. People and their families don't like that. It's not a specific treatment. But as I've tried to emphasize, for some people, it's the most appropriate treatment. Chronic indwelling catheters, as you should know, have specific indications for significant irreversible retention, skin problems that can't heal in the presence of incontinence, and for patient comfort and preference. Reversible causes, you can modify fluid intake, reduce caffeine intake, modify drug regimens if feasible. People don't have to take a loop diuretic. They could take it at different times of the day if that's better for them. And we already talked about the other conditions there. Now, bladder training is what I call a patient-dependent, a resident-dependent intervention. It requires a cognitively intact, functional resident to be educated and use urge suppression techniques with or without biofeedback. And it's hard to do that. This is pictures of me at different weights again, where I was in Europe and I really had to go after having some coffee, and there were toilets, but they cost money to go into, and I didn't have any change. So I was fortunate that I was taught pelvic muscle exercises. But this is not a pelvic muscle exercise, and that's not a pelvic muscle exercise. Pelvic muscle exercises are very specific. They have to be taught and learned and practiced and used in everyday life. And a lot of nursing home residents just can't do that. And we know that a lot of the etiology of incontinence in older nursing home residents is just immobility and or poor cognition. And they need assistance going to the toilet. Okay, so that's a common problem. And there are interventions that are dependent on caregivers. And we've studied, Dr. Schnelly, Dr. Simmons's worser half, developed a prompted voiding, which is a specific behavioral protocol with the opportunity to toilet at regular intervals. It's not putting the person on the toilet. It's giving them the opportunity to toilet every 2 hours, giving them assistance, giving them social interaction and feedback, and encouraging fluid intake. We even tied exercise to it. And we showed, what this graph shows is in the orange, there were a group of people who we treated in 7 nursing homes with prompted voiding in the orange, who essentially became continent during the day. It didn't work during the night, but about 40%, close to 40% of the people we did prompted voiding on with became continent during the day. So they were responders. So, one of the key points I want to make to you is that if you do prompted voiding for 3 days, a toileting trial, you can identify those people. You can see who becomes dry. So you can target responders. It's inefficient to toilet everybody. So there are people who don't respond, and it's not effective at night. And that led us to a whole series of studies on sleep in nursing homes. So there's drug therapy. I'm not going to go over this in detail in the interest of time. I'll just say that one thing, and I'm not a consultant to any of these companies anymore, that there are new medications that do not have as many side effects, including mirabegron, which is mirapetrol, and vibegron, which is Gemtesa. They do not have the concern about cognitive side effects or constipation and dry mouth that all the other drugs do. I understand they're expensive, but they're much better tolerated.
Hey, Dr. Ouslander, we had a couple folks in the chat mentioning that they were interested in seeing these slides. Are these something you'd be willing to share, or are these something that?
Yeah, I sent you the slides.
Yep, I have. I just wanted to make sure you're okay with me.
Yeah, that's why I sent them.
Perfect. Thank you so much.
Yeah, sure.
Great.
I didn't send all the cartoons, but I sent the slides. So you have to be very selective about drug therapy, but some people will benefit. So you only use drugs in highly selected people, combine them with a toileting protocol if they need toileting assistance. They can take a month or 2 to work and watch for side effects. So I'm just going to go over some 6 steps here and then I'll finish. Some key points: determine resident and family preferences for care, identify and treat reversible causes of incontinence, identify criteria for further evaluation if you think a patient needs it, give a trial of prompted voiding. 3 days, 2 days, 3 days. If they respond, continue. If they don't respond, consider further evaluation or adding drug therapy if their symptoms are appropriate.
Dr. Ouslander, can I ask a quick question?
Sure.
I know we're about to end. It'll wrap up real quick, but a lot of folks wonder if targeted toileting programs can really affect fall rates. Can you speak real quick about that?
That's an interesting question. So I don't know that we know the answer to that, but it makes sense. And I do think that it is in people who fall on the way to the bathroom, they should be on some type of toileting program. I mean, we did a study of toileting and an exercise program called FIT, Functional Incidental Training. We did a randomized trial, and the fall rate was reduced in the intervention group, but we couldn't solely attribute that to just the toileting assistance. There were other things, there were other parts of the intervention, but I think it makes intuitive sense that if somebody is trying to rush to the toilet in the middle of the night or unsupervised, that can interfere with fall risk. I myself am a geriatric geriatrician, so I have a neuropathy, I have a foot drop, I'm on Eliquis, I'm at fall risk, I don't want to bleed into my head, and I have to urinate 2 or 3 times a night, and I use a urinal. I'm not going to get up and risk falling down. So I think, and when my mother was living with us, we made a single exit from her bed, and 2 feet from that exit was a portable toilet. So I think there are things you can do that will help prevent falls, and those types of intervention, as well as drug therapy if it's needed.
Great info. Thank you.
So I'll finish up. We published some forms you can use to do trials of prompted voiding. And I'll show you pictures I always like to show. And that is, it is very difficult to manage incontinence in a nursing home. It's like trying to toilet train a resistant child. I have a 2-year-old grandson living with us now, and he goes potty, potty, but he knows when he has to go, but he doesn't always wait. But you also have to be realistic, and a urologist gave me this slide many years ago, and you can't do what the urologist says they can do. You have to have reasonable goals, and those goals can be to be able to sit comfortably, drink a non-caffeinated beverage, and sit on an upholstered chair like that and not have to worry about wetting it. Your goals have to be reasonable. So I'll be happy to answer any other questions. Time is officially up. You can always send me questions. Isaac has my email. It's on the first slide here. You can always send me questions by email. And all of this is written in textbooks. All of what I said is in a textbook called Essentials of Clinical Geriatrics.
Awesome. Well, I really enjoyed the presentation. I don't know if there's any other folks who have questions in the chat, but I'll make sure I disseminate the slides when I send out the recording of the webinar as well to the kind of listserv we have of all the nursing homes who are part of our collaborative. So I'll just pause really quickly to see if anyone else on the call has a question. And if not, you can always just email Dr. Ouslander directly. I'll be sure to kind of highlight his email when I send out the slides on the back end, and his email's on the slides as well. But nonetheless, I want to thank Dr. Ouslander. I'm also really looking forward. He's going to be doing our presentation next month as well on his intervention called Interact, which is used to reduce the frequency of transfers to hospital, which should be really interesting, and I'm really looking forward to it. So hope you're all able to join that webinar as well. And I just want to thank everyone for their attendance today.
Yeah, thanks for taking the time. I know staffing is tough, so thanks for taking the time. I appreciate it.
All right, thanks everyone. Thanks, Dr. Ouslander.
Okay.